Welcome back to day 3 of Virta's Beyond Telemedicine conference. I'm Dr. Sarah Hallberg, Medical Director at Virta Health, and I'm excited to introduce our final session on a very important topic addressing health inequities through virtual care. While it's clear that broadening telehealth has the power to be a force for good, bringing healthcare services to underserved populations in both rural and urban settings, it also has the potential to widen disparities for those lacking resources like stable internet. Today, our speakers will explore the question, how can we ensure virtual care lives up to its promise and narrows health inequities more than it widens them? We'll start off with an overview of health inequity in America today from former CMS Administrator Dr. Don Berwick. Then we'll move into discussions of how this issue affects different populations, such as veterans, Native American tribes, and the unemployed. Here are our speakers. Dr. David Shulkin, former Secretary of the U.S. Department of Veteran Affairs. Dr. Setu Vora, Chief Medical Officer, Mashantucket, Pequot Tribal Nation. Emily Barson, Executive Director of United States of Care. Dr. Lori Zephyrin, Vice President of Delivery System Reform for the Commonwealth Fund. Dr. Rishika Fernandez-Poulet, founder and CEO of Iora Health. And Dr. Mark Smith, founding president and former chief executive officer of California Healthcare Foundation. Thank you for joining. We hope you enjoy the session. An overview of health inequity in America from Don Berwick.
Cross-bridging everything is inequity. And I want to dive into that one a little more. Inequity plays out in the COVID environment all over the place. This is an interesting slide that shows unemployment playing out in inequity. In Massachusetts, my state, we had a report on vulnerability of jobs during the COVID epidemic. Look at the scale here. For people whose income band is $20,000 to $25,000 a year, 76% of their jobs are threatened in the COVID epidemic. For those at the higher levels of income, over $70,000 a year, that number is 2%. So there are very regressive economic effects of the pandemic and very regressive healthcare effects. The inequity plays out also in racial and socioeconomic associations with COVID and its mortality rates. Overall now for Black Americans, the death rate from COVID is about 2.4. It's actually a little bit more than that, 2.7 times as high as the rate for whites. It's also higher for Asians and Latinos. I recently saw some data, which I don't think is published yet, which is that for people in the middle part of their lives, 25 to 49 years of age, the Black to white death ratio is 7 to 1. So we're seeing a highly inequitable play out of the effects of COVID on African Americans, people of color, and the poor. I want to talk a bit about poverty in this country because it's going to cycle back as a kind of takeaway from the whole COVID episode. Poverty rates in the United States are not low; they're high. Overall, in 2016, you see the rate of 12.7%, which much higher rates of poverty for people of color. 18% of kids in the United States live in poverty. 50% of the kids in the United States are born into Medicaid. Let's take another view of it, though, which is racism. This is redlining. This is what redlining looks like. You see the red marks on this map of San Francisco. That's where, according to the Homeowners Corporation, mortgages should not be issued because of racial distribution and hazard. This is the original redlining, in which race, poverty, and inequitable access to opportunity services. This is the map in San Francisco of the lowest performing public schools in the San Francisco area. This exact same geography as the red lines from the 1930s. This is the age-adjusted preventable hospitalization rate for adults in San Francisco a few years ago. Exactly the same distribution as redlining. Poverty and racism and inequity infuse the American society. This is an example of a so-called subway map in New York City. That lower circle is Midtown Manhattan, where people average income is about $180,000 a year. 3 miles away, that upper circle is the South Bronx. And between the Midtown Manhattan and the South Bronx, when you get on that subway train, you lose 6 months of life expectancy for every minute on the subway. 10-year difference in life expectancy. In Chicago, between the Chicago Loop and West Chicago, that's a 16-year difference. In Flint, Michigan, from poor to wealthy areas of Flint, that's a 15-year difference. That is an amazing amount of life lost just associated with place, wealth, income, and race. It plays out in life expectancy. This is the life expectancy in the US by year of birth, people born in 1920 over to people born in 1950. You can see the poorest 10% have had very little gain in life expectancy among men compared to the richest 10%. Women at the lowest levels of income in our country have actually had a decrease in life expectancy through the years 1920 to 1950, year of birth. This is the sequence we're trapped in. It's the COVID sequence. It's the play out in COVID of an underlying structure in American social policy, regressive policies, ungenerous in general to people of lower income and color, deep in poverty, increased isolation, deaths, so-called deaths of despair in the language of Angus Deaton and Ann Case, and poor health. And yes, more people in poverty, more people in lower income, more people of color die in the COVID epidemic than people who are better off. It's a tragedy for us all. I absolutely know that, and I'm not saying otherwise, but I think without attention to inequity as a fundamental determinant of health in America, we won't get health. Michael Marmot says inequities in power, money, and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health. I can't close this without mentioning the parallel with the COVID epidemic in the United States of the consequences of racism as so tragically represented in the murder of George Floyd, and people now in the streets once again calling out the residue of our heritage of slavery and Jim Crow and racism in this nation. It plays out in COVID as well. And most of all, I think, begin to take more seriously than we ever had before in the United States, this deep, deep problem of inequality and racism and exclusion at the foundation of poor health in America. That's going to take a lot of hard work and a lot of commitment, and I'm up for it.
Using technology to improve access to care for Medicare populations during COVID-19.
So we know that there are huge disparities in outcomes based on race and ethnicity, right? And that's how it happened and existed for a long time. It's dramatic, right? The life expectancy can vary by 20 or 30 years, depending on the neighborhood you live in and whether you're in a poor Black neighborhood or a rich white or Asian neighborhood, right? So huge. COVID has made these worse. Like if you look at the death rates, the hospitalization rates, they are disproportionately in neighborhoods that are poor and Black and brown. The reaction of all of us in the industry has been to move to telemedicine. And unfortunately, what happens is a digital divide. And by the way, we're seeing the same thing in schools right now, right? But the digital divide exists, and you can make these inequities worse, actually, by trying to solve the problem going and using technology. So we have taken that really seriously. We have some really interesting data. If you look at some slides that will show, the first slide really looks at our response to COVID. And we were able to, like many people, right around when this happened, around the middle of March 14th, rapidly increase the number of telemedicine visits we were doing. And so on the slide, you see the blue bars, which are the number of asynchronous emails and texts we're doing. The red bars are the in-person meetings, and the yellow bars are the virtual meetings, video or telephone. And you see the break point right around March 15th, where overnight we started dramatically dropping the number of in-person visits. We dropped to about 8% in person very quickly. Picked up, though, dramatically the number of emails and texts, and way picked up the number of virtual meetings. So we actually doubled the contact points per patient. We thought it was really important that we touch our patients a lot to tell them, stay out of society. You need to shelter in place. You are vulnerable for COVID. Despite what your governor of some of these red states are telling you about getting tattoos and going to the beach, that doesn't mean you. you need to stay away from the virus. Don't let your grandchildren come and visit. Wear a mask, etc. And by the way, we were very successful. We were able to get, our hospitalization rate for COVID is tiny. It's about 1.5 per 1,000. It's less than half of what the Medicare average is because we were able to get to patients. So our second transition really was moving to video. We started by doing it, and a lot of those were phone calls in the beginning. And then we said, phone is all well and good, but if we wanted over the long term to take good care of people, video is so much better to be able to interact with patients, to make good clinical assessments, and to maintain the relationship. So we dramatically increase it. So you look again at this graphic, the blue is in-office visits, the red is phone, and the yellow is video. So in the beginning, right around the middle of March, we dramatically dropped the in-person visits and did it all by phone. And then about 2 weeks later, we said, now it's time to flip the phone to video and get both teams and the patients comfortable doing it. And we dramatically improved and increased the number of videos. So we went up to doing 70% or so of our interactions by video, about 20% by phone, and a little bit in person. By the way, it was really important to us to keep every one of our practices open the whole time of COVID. There are a set of things that people need in person, and we should be there for them, right? So some practices were scared or couldn't do it, and they shut down. We didn't think that was the right thing to do. So see them in person when we need to, but the vast majority by video. Now, the problem, again, are these barriers. So we actually looked at what the barriers to video visits were and polled our patients, asked the customer. So about 2/3, these are seniors, these are low-income seniors that we're talking about. The next slide shows that about 65% of our seniors did not have a barrier. They could easily do a video visit with us. But about 35% had a problem. But this is about the same number that a recent study in JAMA identified. About 30-ish% of people have a barrier. About 3% of them are cognitive. They're demented. There's no way they could do it. About 10% is actually patient preference. They just didn't want to even try. 16% lacked a device that actually had a camera and could do it. And a small percentage had trouble with internet and data plan limitations. What's interesting, if you look at, we did it by decade. Obviously we have a handful of patients who are not seniors, and they almost entirely can do this. If you look at patients in the 90s, 46% of them actually had no barrier. So over half had a barrier. 51% in their 80s, 64% in their 70s didn't have a barrier, and so on, right? So it scales with age. So then we had to figure out, how do we solve this? And so really we had several solutions, but the big one was we need to help the patients cross this divide. So we started providing tablets to people, which were hooked to 5G networks with simple app to use. We tried mailing it to people. That worked for some of them, but worked the best was actually having our health coaches, our models built on having these community health workers and health coaches, go to people's houses, hand them the tablet, be there for tech support, have them use it, the doctors in the office, and then hand back the tablet, clean it, and go to the next one. And we were able to, which I'm very proud of. If you look at the distribution of video across different decades, and again, here we look at by decade, people in their 90s, their 80s, their 70s. The green bar is the video. The blue is the in-office visits, and black is phone. You notice just at a high level, these are pretty similar across the decades, right? So the percentage of video encounters was 37% in the 90-year-olds, 43% the 80-year-olds, 48% in the 70s, and 48% in the 60s, right? So we kept it pretty good. We were able to get a significant number of our 90-year-olds to be able to interact with us by video, and we kept the sort of in-person visits about the same. This is where we are now. About a quarter to a third of our encounters are being done by phone, about a quarter of it is being done in person, and the rest by video. We think that's about where things are going to shake out over time.
Addressing health inequities in the veteran population. What was the state of the Veterans Health Administration at the start of your term as Undersecretary in 2015? What problems were you looking to solve?
Well, I came to VA because it was in crisis. As some people may remember, I was a private citizen at the time. In 2014, there was a national crisis. It was called the wait time crisis, where the allegations were that there were thousands of veterans waiting for healthcare, and some of them dying waiting for healthcare because the VA just couldn't take care of them. And that was a result of really a perfect storm of the complexity and the number of patients who were coming back from Afghanistan and Iraq, sometimes with very complex illnesses, traumatic brain injury, for example, but also because of the Vietnam veterans who were getting close to about 70 years of age, and they were the largest number of veterans in the VA system. And as people know, when you get older, you require more healthcare services. And of course, 40% of veterans live in rural areas where we really do have problems with access to the number of healthcare professionals that we need and the right match of expertise that we need, particularly in rural areas.
What were a few of your key learnings from the Veterans Health Administration? In particular, how did you use data plus technology to solve for healthcare issues specific to veterans?
There are a number of areas that I do now recommend to those that are running private sector organizations. And one of them is how to use the tremendous resource of people that work in your organization. And when I was addressing the wait time crisis, one of the most controversial things I had to do, particularly in the beginning, was to make a decision whether I would grant advanced practice nurses and pharmacists full practice authority. That means to give them the independence to practice at the top of their license, not necessarily under the supervision of a physician. It turned out to be a very important decision, one that I feel very proud of, because advanced practice nurses and pharmacists began to contribute in ways that I had not imagined and began to take the weight off of our primary care physicians who were overburdened and frankly burning out and leaving the VA system. So allowing pharmacists to be able to prescribe medications and take that burden away from primary care doctors, to allow advanced practice nurses to be able to work in areas where previously there had been shortages and we were understaffed, turned out to be tremendously important. I also saw the power of predictive analytics. VA was tremendous in its ability to take a look at data and to look forward in its ability to help populations. So I asked the question one day when I was secretary, how many veterans had hepatitis C? Because a new drug had just come out that could essentially cure hepatitis C, which I thought was phenomenal. And almost immediately I got an answer back. There were 163,000 veterans with hepatitis C. And I said, well, we're going to cure hepatitis C then. And we went out and systematically identified all 163,000, proactively called them, brought them into an organized program where we were able to treat them. And today there are less than 10,000 veterans who have not been treated for hepatitis C. And so that's really the power of being able to use an organized system of care, to be able to use population health strategies and use data to really make major changes among large populations of patients. And, I began that work right before I left, doing the same thing with suicide. The issue of suicide among veterans became my top priority, with 20 veterans a day taking their life, just a staggering number. We started to use predictive analytics in the same way, identifying those at highest risk, calling those patients, bringing them in, and beginning to identify ways that we could help them, a lot connected to social determinants, in fact. That's really what I think the private sector needs to be doing. They need to be looking at the communities that they serve, looking at the tools available to them, being proactive in outreach, and being able to use the resources that they have to be able to make the biggest impact on people's lives.
What are your hopes for the future of healthcare for veterans?
The moonshot that I developed at the Department of Veteran Affairs was to be able to create the home as an environment where veterans could get the care that they need. This is clearly a long-term vision, but it's one I still very much believe in, and believe that this can be accomplished and needs to be accomplished by those that are working in the field, to be able to combine what we know about telehealth with a service delivery model, an economic model, to be able to align both the clinical goals and the economic goals of a system of care, and of the way that government looks at things as well, to be able to implement the home as an ideal environment to be able to take care of people if that's where they choose that they want that care delivered.
How virtual care can address gaps in women's healthcare.
When we think about the importance of a primary healthcare system, I mean, primary healthcare is the foundation of, really should be the foundation of any healthcare system. And so health systems tend to be siloed and fragmented. These silos make it busy for busy women that make CEO health decisions for their family. And so, when we think of some of the categories of gaps and barriers, there's a gap in frameworks, and having a framework of healthcare delivery that really takes into account women's needs, whether it's biological or structural or social needs, and incorporating that into the design of primary healthcare. For example, having trainees and providers more proficient in caring for women and healthcare needs of women across the board, so that women don't have to go to a primary care provider and an OBGYN provider, another provider, another provider. How do we synchronize those systems? We also have to think of gaps that relate to social inequities, right? Whether it's pay equity gaps. We know that women make 60 or 70 cents on the dollar, whether they're Black women or white women, compared to their male counterparts. And that can make it very challenging to access care, because women may need to have multiple jobs or have competing demands, or may not be able to get appropriate health insurance. And so we have to understand social needs and social challenges that also create these inequities. We also have to address gaps in really addressing women's health care across the life course. And really, as women transition, whether it's transitioning into maternity care or transitioning into as women age, really ensuring that as women are going through major transitions in their life, that there are providers that can address healthy aging, can address whether it's end-of-life care, or have training to address healthy aging, or have the expertise. That's critical as well. And I think the other piece, which is also important when we think about gaps and structural barriers, we also have to understand that the gaps that are created by structural racism, whether it's structural racism causing gaps in access to quality healthcare, or gaps in safe housing conditions, or safe having access to jobs that actually pay a living wage. So we really have to also be able to address gaps relating to structural racism and build that into our model of care, so that we can ensure that we're providing equitable care and can advance health equity. In terms of how telemedicine can fill in those gaps, I think there are a lot of opportunities to do that. I think it's really important for, as telemedicine is being designed, to really think about the person that the care is being developed for, right? And so, for example, there are telehealth brands that may address generally primary health care, or generally address behavioral health. And so there's an opportunity to incorporate women's health needs into those models, right? They may not specifically focus on women, but can have content and can really have providers that really understand, for example, the needs of women in the context of mental health and behavioral health, because there are some nuances there, and there are providers that specialize in that. The other way is really also advancing innovation around telehealth for women's health care in general. And so whether we're talking about maternity or menopause care, or infertility, or care relating to needs across the life transition, really thinking more broadly in terms of what are areas that need a little more investment. There's a lot of work that I think needs to be done in the menopausal space. Around maternity, there's an importance for doing more work in the postpartum space as well. When we look at data specific to maternal mortality and morbidity, most of the deaths occur after delivery. And so what are innovations from delivery to a year out that can be developed that can really leverage telemedicine opportunities? And so I think there's an opportunity for telemedicine to dive deeply in certain areas that have been less of a priority area. And then lastly, I'd say there needs to be some ability to break down the silos, because in the first area I talked about, for example, behavioral health integration and incorporating women, or primary care telehealth companies incorporating women, or if you dive deeply into some of the specialty areas, but there also needs the ability to be able to connect the silos. And so I think there's a role for digital health companies to advance women's health by helping bridge the silos across services that may dive deeply, but there aren't the linkages that women require to make care delivery easier for them.
The grave health inequities in Native American populations.
So I'm the Chief Medical Officer of Mashantucket Pequot Tribal Nation, and the people of the tribe have been at the same location for over 10,000 plus years. And the history of the tribe is one of great challenges with great trauma resulting primarily from the colonial contact, as you could imagine, that led to almost an extinction of the tribe at one point, and they came back. So the loss of culture, loss of language, loss of food practices, dislocation from their native lands, forced assimilation, all that resulted in tremendous amount of historical trauma that we now know impacts even subsequent generations through the phenomenon of epigenetics as well. We see the impact of economic devastation with the COVID, resulting in increased stress, financial stress, social stressors, so that it leads to more disruption, increased exacerbation of mental health disorders, and resultant substance use in some cases. Certainly inequities in terms of access are made even worse because now patients cannot go get appropriate care, preventive care in a timely fashion. Even before the pandemic, our overarching goal was to build a culturally sensitive health enterprise that has both high touch in keeping with native traditions and also high tech to keep up with the advances. What the pandemic did was to accelerate that process of adoption and change, mainly to make sure that we preserve and increase the access. So overnight, virtually, we had 90% or more of our clinical encounters go digital with the telemedicine platforms. At the same time, we wanted to certainly focus on certain key drivers of healthcare, morbidity and cost, diabetes being one of them, cigarette nicotine addiction, not the ceremonial tobacco, but the commercial tobacco is the second one. Addressing behavioral health through telemedicine has been a main focus as well. And then at the same time, we also started addressing even more so certain unmet social needs through digital applications, such as non-emergency medical transport. How may we connect people with care as a defined benefit? So the tribe has its own healthcare entity, Pequot Healthcare, and we administer our own self-funded, self-insured health programs, insurance. And we have value-based insurance design where we can cover what appears to be more of a social care as part of the health benefit. So using digital tools to connect members with care with all these modalities has been really enhanced due to COVID. I think as we collectively work through the pandemic, how may we reconnect with the basics of how may we reconnect with the human touch as we incorporate more digital in our tool set, and reconnecting back with ancient practices of both nutrition, food sovereignty, linking that back with health sovereignty, where the decisions and the design of health program are done by the members who use that system. I think that grassroots movement at each tribe, at each village, at each city will likely result in better overall population health, where we have the best of the individual health beliefs and their design, plus the emerging technology platforms that are so powerful.
how the current unemployment crisis is creating a healthcare crisis.
The unemployment crisis that we're seeing is actually a healthcare crisis as well. Our system entwines our healthcare security with our jobs. And so losing a job often means losing healthcare, access to affordable healthcare, which is never a desirable outcome, but certainly even more dangerous during a pandemic. From our research and listening to people about their healthcare experiences and needs, people want to be able to have the freedom to choose their job based on factors that don't include whether or not they will have dependable healthcare coverage. There was a recent report showing that 27 million people have lost their healthcare coverage during the current COVID-19 pandemic. Minority population groups are being disproportionately affected by both the unemployment and the loss of coverage. And in addition, employers are facing financial pressures to reduce coverage for those who do remain employed during the recession to cut costs. So we think it's really important to take this time to question our decades-long approach as a country to marrying health security with job security. We need to find alternate approaches so that losing a job doesn't also mean losing your healthcare security. Insurance from employers, as we know in recent years and decades, has been getting increasingly expensive, both for the companies and for the people they employ. The existing regulations and programs meant to curb the loss of health insurance due to unemployment are antiquated and often unaffordable in reality. It's really important that that there are options of healthcare coverage, that there are insurance that people can buy at a reasonable rate for their family budget, something that they know will cover the care that they need, will allow them to have a regular source of care and a affordable source of care, and offering options more broadly than the really restrictive employment-based insurance system that we currently have, and which our infrastructure and tax system encourages, would free people up both to leave jobs that maybe aren't right for them, certainly if they lost their job. And we've also seen that it offers entrepreneurs, many of whom are part of this audience, the freedom to really avoid feeling locked into a job that isn't feeling their full potential in order to keep their health insurance.
Lessons from California Healthcare Foundation, opportunities for telemedicine, and where it falls short.
So one of the reasons I'm excited about telemedicine is that I think it can really be a big and important tool in addressing some of the inequities and disparities that exist in healthcare. So I think that's a positive. I'll talk about some of them while recognizing that telemedicine, like any other tool, is no panacea. So one of the big problems with healthcare is the geographic maldistribution, unequal distribution of physicians, of hospitals, of diagnostic and other facilities, and down the line. And so one of the ways in which I think telemedicine can address that is, for instance, in behavioral health and other specialties, connect people to resources that may not be around the block or even in the same county, but that can function well enough by phone, by video, by other means, to eliminate the fact that the closest psychiatrist, particularly the closest psychiatrist taking Medicaid, or the closest neurologist who will see uninsured patients, may be a 50 or 100-mile drive away. So first, there's geographic accessibility. Secondly, I believe that telemedicine, if it's in the right environment, can reduce the cost of healthcare. And so the principal problem for many low-income people is not so much that it's geographically maldistributed, but that it's economically maldistributed, and without access to adequate insurance, people go without the care they need because they can't afford it. Anything we can do to reduce the cost of high-quality care, including but not limited to telemedicine, means increased access to adequate care for people who are currently shut out for economic reasons. Thirdly, there are issues of special challenges for people of color, or who may be better cared for by dermatologists who have expertise in higher melanin skin, by people who speak languages other than English, who may not be able to access a physician who speaks Tagalog or Spanish in their neighborhood or with their particular insurance. One of the things that we need to think about is making broadband much more ubiquitous and much more affordable. Unequal access to broadband, I think, is going to have a wrenching effect on the existing disparities in educational opportunity for low-income communities. And I've been struck for many years about the fact that healthcare was probably 10 years behind every other service industry in its application of information technology. On the one hand, there's great biomedical technology of gizmos and gadgets and machines that whir and go bing in the night, and drugs and vaccines, but the nuts and bolts of how we interact in the healthcare system remain pretty much the way they were 20 years ago. And that's not true for shopping or banking or research or almost any other, or dating or almost any other service industry. And so if there's any silver lining of this horrible pandemic, it may be that it has helped accelerate the adoption of modern IT in healthcare in a way that was poking along, but not with nearly as much urgency as I would have liked. And I'm hopeful that we will emerge with a greater use of the tools that are available to us to make healthcare more broadly equitable and affordable to people.
Thanks all for joining that session. And thank you to all our panelists for diving into this important issue. It's clear that while we've made a lot of progress in addressing health inequities, there is still a really long way to go to create a system that is truly equitable for all. I hope that the expansion of virtual care will help get us at least part of the way there.